But let's switch gears a little bit and talk about the transplant-ineligible patients. And I have to say that's a distinction that drives me crazy because I don't like the 65 arbitrary distinctions that the Europeans have given us. So for me, it's about frail, the truly frail people that even you're going to have trouble limping them through their initial therapy. So we had melphalan-based approaches for decades. We replaced that with Lendex. SWOG gave us VRD being better than RD for those patients. And now we have SODS trial with DRD. Where do you guys sit on how to use that and how do you approach your folks?
I mean, I would say that the two big trials obviously are Alcyone and Maya. And those are both daratumumab containing trials. And they're both large phase 3 trials in the transplant ineligible. And the daratumumab containing arm in both trials had overall response rates of greater than 90%, had improved PFS and improved MRD negativity rates. In fact, the 30-month PFS in the Dara VMP was 60%, and the 30-month PFS in the Dara RD was 71%. So that's pretty impressive, actually, for a triplet and a quadruplet. Now, this quadruplet really we don't use much in the U.S., and that even though it's an approved regimen in the U.S., has not really caught on, and I don't think many of us have used it. In fact, I don't think I've ever prescribed it. But Dara RD, especially for the transplant ineligible patients, that's a great regimen. And you know, in terms of quality of life and the ability to continue the regimen for a long time, it's a very easy regimen to give, especially after you're getting to every 4-week daratumumab.
So Saad, you presented some data on age and the effective age. You want to talk a little bit about that?
Sure. So one of the unique features about the Maya trial was the proportion of patients enrolled who were 75 or older, and that's the patient population that you know, we truly believe are transplant ineligible. So this analysis actually looked at response rates and median PFS for that specific group, and you know, there were no differences between the younger than 75 versus 75 or older in terms of the PFS benefit that patients get. The only thing that we saw, again, small numbers of patients, only 14% of the patients were high risk, was again that benefit was not seen for the high risk patients in Maya. And that's where, you know, I would still be on the fence. I would still be thinking about, you know, maybe adding a PI to the IMiD instead of Dara for those patients. But I think from the tolerability standpoint, I agree. Dara RD would probably be the easiest regimen to give to patients. And in fact, all of my patients who were on the 3-drug arm on Maya were taken off of Lendex because of cytopenia issues and have been cruising on just once a month Dara. So I think that's the other thing, that you would be able to take patients off of the partner drugs and just keep them on Dara.
Mm-hmm. Krina, you were mentioning QOL before. How do you think that fits in with what we know about whether it's Dara RD or VRD? And we know that Sonia's actually has a trial in progress using VRD plus Dara for a frail patient, which maybe in the Dutch patients are much more frail.
Dutch and German patients.
So yeah, so coming back to the definition of frail and who really is transplant ineligible, and I think for me, 80% of my patients still go to transplant. So you have to have an organ reason as to why you don't get a transplant, pulmonary or cardiac. And I think quality of life is so important in these patients, right? Because I don't want to harm them. My goal is to help them and actually improve their quality of life. And what was surprising at the trial that was presented, that the quality of life in the Maya, the DRD versus RD, patients actually had better quality of life with DRD. So adding that third drug for a frail patient doesn't actually make them more toxic, right? And the idea was that there were less patients that came off of DRD as well compared to RD. And so maybe, hopefully, it was because better disease control, potentially. So I think those are really important factors, especially in our frail patients, to look at.
So I think you raise a really important question, and I think we have 5 transplanters sitting at the table here. So, you know, whenever I bring up the artificial barrier of 65 and I'm in Europe, they all look at me like I'm crazy. But I think practically speaking, I mean, how do you all approach transplant in a 70 to 74-year-old? I mean, at least at our center, it's not a no unless they're, as you mentioned, pretty frail or, you know, they have uncontrolled diabetes or something else. I'm just curious how, on the West Coast and the East Coast, how it's managed.
Well, a California 75-year-old is a Atlanta 50-year-old. So, but I think, you know, the data we do, we obviously don't have large face.
California 70.
Yeah, we don't have large phase 3 trials, but we have comparative studies in terms of transplant-related mortality is similar, engraftment is similar, and PFS benefit is similar. So I have no issue in terms of transplanting that 70 to 75-year-old.
It is really about fitness more than age, and I think we all believe in that. And most of us can tell the first 5 seconds that we're in the room whether or not that patient is really going to be a transplant person or not. And I think we all go to transplant as to provide a deeper response.
I agree with that. And then, there are patients who may not look like transplant eligible at the time when they're diagnosed because of sequelae of disease. But that too gets better, as you cyto reduce and their performance status improves. So I think, again, it's not a one-time point evaluation. I think we kind of look at those patients during the course of induction. Many times they may actually look transplant eligible, but they declare themselves as ineligible based on how they handle induction.
But I mean, the one point I would make is, the alternative you look, is maybe shifting, right? Because the alternative is you're going to keep someone in RVD for 8-12 cycles with neuropathy in a patient over 70. Now with Maya, the alternative may be better. So, that may be a shift a little bit in our thinking as well.
So you would say put them on something less intense and don't even collect cells and think about transplant. I guess that's the question, because sometimes you can reduce the risk of long-term complications by sort of consolidating early and moving on.
But we never really just move on, right? We're always going to keep them on len or keep them on something. Right. So, I guess the question becomes, do you do just DARA-RD, collect cells, but not transplant in someone in that 70 to 75-year-old? I don't think that that's unreasonable. It's a discussion to have, at least for standard risk patients.
Yeah, and we're really, we're quick on decreasing the melphalan to 140. And so to me, 75 is an artificial age. I have 84, 85-year-olds that go to transplant. We worry about MDS, and that's something we're looking at, of course. But my melphalan 140, they do really well. They don't have side effects, and then I get off the Revlimid, after a little while, and they have great, happy lives, golfing, and doing everything you want to do again. So I don't think age should be a cutoff.
But I do think you raise a good point, because as we learn more about clonal hematopoiesis, right, and increasing as you age, I think that may also make us a little bit smarter about deciding if we're going to transplant someone who's older.
I think that's some data being generated by several groups now. When we're doing those marrows at the time of diagnosis, looking at CHIP in those patients from the get-go, and maybe we'll have more information about which patients to avoid len maintenance and
I was going to say, do you want to give that patient DARA-RD then, if you're worried about CHIP? Let's go back to your paradigm-changing approach here.
Maybe take them off of Lendex quickly and just keep them on DARA.
Yeah.
Interesting. All right, good.